We shall now go on to our next speaker, Dr. Sharmila, who's a senior medical consultant at Arvind Eye Care Systems, Madurai, and one of the senior consultants in the glaucoma services. And she is going to tell us something different, a combined surgery again, but a combined SICS trap, the tips and tricks. On to you, Dr. Sharmila.
Thank you very much, madam, for that kind introduction. And I hope my slides are visible and I'm audible also. Just
Yes.
Thank you so much. Yeah, so I'm going to be talking about combined SICS trap, the tips and tricks involved in this. So this is a beautiful picture of nature at its best. You can see the coast, the beach, the sand, the waves, the sea. It's definitely beautiful. It's not my vacation picture. As probably would be expected by Dr. Chitra, this is a zoom picture of pseudoexfoliation syndrome. So why I put up this picture? We all know that cataract and glaucoma often coexist, and phacoemulsification with a combined trabeculectomy is primarily the best option in these eyes. However, we may not be able to do phacoemulsification in all situations. So choosing the right technique is the first tip I would like to give, depending upon the patient, depending upon the need for that particular patient. So that is a tip number one. So tip number two is an adequate preoperative planning. I always believe in doing a good planning before anything, whether it is surgery or whether it is in any other situation. I always love to do a good preoperative planning. So I do a careful slit lamp examination. I assess, most importantly, the size of the pupil, the grade of the nucleus, the zonular integrity, presence of pseudoexfoliation, the status of the angle, any peripheral anterior synechiae that is present. All this will give me a clue as to what kind of surgery I'm going to be doing for that particular patient. So the choice of surgery is very, very important. And even when I'm going to do a technique, the SICS trap, there are different techniques of doing an SICS trap. So I will probably choose which is the technique that I'm going to undertake for that particular patient, and using antimetabolites, what is the mode of delivery of the antimetabolites, the type of sutures I'm going to use for those patients. So all this preoperative planning is really very crucial for a good surgical outcome. And tip number three, we all know that Peng Tiko is a big man in glaucoma surgery, and he has framed the 5 mantras for a good surgical success in trabeculectomy. So basically, the first one is treat a larger area with antimetabolites. Second thing is you direct the flow posteriorly. The third thing is you always make a larger scleral flap and do not cut it to the limbus, and make a single scleral punch sclerostomy. And you also choose to do more of releasable or adjustable sutures than the fixed sutures. So now moving on to the real surgery. So there are a lot of intraoperative tips as well, which will be very useful to have a good successful outcome, even if it is going to be a larger incision surgery like SICS trap. So the first thing which I have not included here is the conjunctival dissection. We all know that conjunctival dissection is a very important step, and we have to carefully handle the tissue with meticulous handling of the tissues with good instruments, and do not cause any undue tears in the conjunctiva, because that might lead to any kind of leaks postoperatively. Tip number two, which is actually the use of mitomycin C injection. So there's always a debate as to how to use mitomycin, whether to use sponges or whether to use an injection, and how much to use and all that. So recently we have moved towards using injection mitomycin over the sponges. The reason for this is it is takes lesser time. There's no dealing with sponges. And we also know that the exact concentration is delivered to the eye. And this can be spread evenly in a larger area. So I'll just show you the video. So mitomycin C injection, what you use is typically the same concentration as what you use it for the sponges, but you take only 0.5 ml of that and then mix it with 1.5 ml of lignocaine. So I prefer to, I'm sorry, this video is. So I prefer to use it 8 to 10 millimeter posterior to the limbus, like what you see here. And then I spread it out evenly and then start the conjunctival dissection after a couple of minutes. So this is the conventional way of using mitomycin, where you count the number of sponges. The first sponge to go inside should be the first one to come out also. A lot of care has to be taken because you have to count the number of sponges. You have to do a thorough irrigation after removal of the sponges, and make sure that you don't touch the tip or edges of the conjunctiva when you're using mitomycin C. So the second tip is wound construction. We all know for any building, the main structure that has to be really taken care of is the foundation. So likewise, even for any surgery, the success of the surgery, like what we heard from Dr. Tamilarasi, beautiful videos she had shared. So it is all depending upon the wound construction. A good wound construction actually saves half your surgery, and as well as it also improves the success. So I would always love to concentrate on the scleral flap. It should be a uniform thickness scleral flap. It should be a larger size or a smaller size, depending upon the length or the density of the cataract. And it also depends on multiple factors. Like one is the skill of the surgeon, how skillful he is in doing that particular procedure, and depends upon patient factors like pupil dilatation, nuclear density, etc. So there are different kind of wound construction. Like triangular flap itself, you can do it like a wide triangular flap incision, or you can do a W-shaped incision with a side SICS kind of an incision, or you can take a rectangular flap, or just do a SICS tunnel-shaped tunnel which you use, and then use that as a flap for making the sclerostomy. The second, these are the videos which I would like to share. So this is what is a small triangular flap with a side incision, what I mentioned. Make sure that you take a uniform thickness of the scleral flap. And when you're going towards the side, you have to be very careful, because you should not have any undue cuts there. And then you just bring it out just like how you're doing an SICS tunnel. So this is one way of doing it. And the other way of doing is make a larger broad-based triangular scleral flap. So this is usually preferred for a slightly more denser cataract. So here you see a larger V incision. And then similarly, you dissect it out with uniform thickness, making sure that you do not cause any kind of buttonhole or differences in the level of dissection. You should have a uniform thickness. Make sure that you take adequate care to maintain this uniformity throughout. When you reach the base of the flap, that is very important. You have to make sure that you angle it a little superficially, so that you can see the blade there, and make side pockets and then do it. The other one is a routine SICS surgery, what we do. So this is a straight incision, and then you finish the surgery, and then the difference will be shown a little later. So the most important step is the internal ostium. Again, the internal ostium also, how much of internal ostium has to be cut and where it has to be done is all, again, important tips. For example, the first incision, what I told, a small triangular incision, you just make a single punch with sclerostomy using a Kelly's punch. Make sure that you meet it till the surgical limbus, that is the blue and the white sclera meets. So this is adequate for this particular type of incision. Whereas if you take a larger, wider, this is in the SICS flap, a straight incision, where you take the midpoint of the incision and then under the scleral flap, make a sclerostomy. And in the case of a larger triangular scleral flap, you can do two with distance or two with distance of the punching. And similarly, you extend it until you reach the surgical limbus. So why this is important is because in the wider flap, you have a wider coverage. So there won't be any chance of hypotonia or overfiltration in these kind of flaps. But whenever you have a smaller triangular scleral flap with the side incisions, it is better to make only a single scleral punch. In case you're making a wider scleral punch, it will be leading to more of hypotonia or overfiltration. So that is the reason why we are doing this. And then the peripheral iridectomy, we all have to make sure that we have a good size peripheral iridectomy. It should be a little larger than the inner sclerostomy opening. I also prefer to use pilomin in some cases where you do not really know how much of iris you're cutting out. So once the pupil is fully dilated in these cases, because we are doing a combined surgery, it's difficult to identify how much of iris you're cutting out because everything will be bunched there. So you can use a pilomin at that particular point of time. So here you can see that in a straight incision. So you lift up the scleral flap and then just pull out the iris and then do a incision there, excision of the iris there. And here you can see that you make sure that it is precise and wash out the tissue very clearly so that there is no iris tissue which is blocking the ostium. So the tip number 5 is good scleral flap closure. So there are different ways of closing the scleral flap, and number of sutures also might be different according to the flap size or what kind of flap you have taken. So generally I prefer to use, in a case of a small incision triangular scleral flap, I put a single fixed suture at the apex. Apical suture is really very, very important. That has to be really tight, and it has to be firm. Always ensure that your eye is firm when you're doing any kind of suturing, because you're doing it under saline, and you need to have to assess the integrity of the wound. And this is a releasable suture where we usually use a 10-0 nylon, reverse the needle, take it out to the cornea, bring it out through the cornea, and then from the sclera, and again to the base of the scleral flap, 4 throws, and then you tighten it. So the advantage of this is there is a small loop here. So it will not cause any irritation by a free floating end there. And this can be pulled out in case you don't have an access to a laser machine for doing a suturalisis. This is very, very helpful. And one other thing what I would like to show is in an SICS straight incision tunnel, you can use just 2 sutures on either side of the sclerostomy, like what is shown here. I always prefer to bury the sutures, because we also heard from Dr. Ravindra, it's very important to flush it, cut it very close to the suture, and bury it under the sclera. And the last step is the good conjunctival closure. We all know that we have to ensure that there is a watertight wound closure. So again, there are different ways of doing it. I generally take a good anchoring suture with the sclera. So conjunctiva, sclera, and then conjunctiva again, and make like a mattress suture here. And you can also do the same thing on either side, or you can pull the whole conjunctiva to one side and you can suture it. The idea is basically to have a watertight closure. Sometimes you might see a small frill of conjunctiva which is very loose at the apex. In such cases, I usually use an anchoring suture where I take a bite from the cornea to cornea, bring it out to the conjunctiva, reverse the needle from the conjunctiva, and then take it out and tie it to the sclera, to the cornea. So there have been a few studies which have compared SICS trap with phaco trap, and this is a very popular study by Dr. Ravi Thomas, where he has compared both, and he has found that there is no clear difference between the two in terms of IOP control, visual acuity gain, or any induced astigmatism. And this is the most recent article which I came across, which was published recently in IJO. They have compared only in pseudoexfoliation eyes the SICS trap versus phaco trap. And again, they found that SICS is not inferior to phaco trap in terms of surgical outcome. However, they found that the zonular dialysis is more in pseudoexfoliation glaucoma in phaco compared to that of the SICS. So the take-home message here is combined SICS trap is a safe and effective alternative to phaco trap in special situations like complicated cataract, poor dilating pupils, zonular dialysis, heart cataracts, etc. SICS trap, though safe and effective in terms of IOP control, it does not improve the long-term web survival because it induces a lot of inflammation intraoperatively and postoperatively as well. Choosing the right technique, therefore, should be based both on patient factors as well as the skill of the surgeon. I would like to conclude by this quote: good surgeons know how to operate, better surgeons know when to operate, and the best surgeons know when not to operate. I always like to be the best of the surgeon, and I decide when not to operate. Thank you so much for patient hearing.
Thank you so much, Sharmila. As usual, nothing but the best could be expected from you, the crispness, clarity, and the kind of videos. But the last take-home message of yours sort of answered one question which I had, because personally, I have done more phaco traps, and I know you are a person who would have done enough of phaco traps and SICS traps too. So though that message tells a final answer, do you also believe that compared to the two, SICS trap versus phaco trap, the final outcome, IOP control or the long-term bleb success, is definitely more query in SICS trap?
This is kind of little difficult to answer because head-on comparison have shown almost the similar kind of outcomes, although we have better benefits with phaco trap in terms of, early rehabilitation, and they just, the recovery is also faster. But in any kind of trabeculectomy, the outcome depends upon a lot of factors. I think it depends upon, how many medicines they are using preoperatively. That also has an influence on conjunctival cytology. It also depends upon everybody's individual unusual healing response, because the body's healing response for A is not the same as B. So a lot of factors come into play there. So, but however, whatever said and done, this has a larger incision. And in SICS trap, what I thought was we are doing same site procedure for both, whereas in phaco trap, we usually separate the wounds. So I tend to do a temporal phacoemulsification and then do a superior trap. So that also might be a little more advantageous, but scientifically, there's nothing proven as such.
Okay, as far as the management is concerned, I would want you to outline how you would do the post-op management in the phaco trap versus SICS trap.
Okay. Pretty much it's the same, because we usually follow that 6 times a day for 2 weeks, and then we taper it like every 2 weeks until we reach for once a day. So it goes up for I think around 2 months, and then in SICS trap we add a cycloplegic. It again depends upon how much of iris manipulation and all that is there, and then generally we stop all anti-glaucoma medications. Of course, we would check the intraocular pressure. However, if there was a preoperative, there is a severe glaucoma, then I tend to keep them on at least 1 drop to have kind of like a safe thing to avoid any undue pressure rise postoperatively, causing compromise on the optic nerve function. Yeah.
Now, you presented a case series randomized control study where you have compared a phaco trap versus a SICS trap, where in those small eyes where you did a prophylactic sclerostomy too. What were your comparative results?
The comparative results of that is in nanophthalmic eyes, just to give others the idea about this. This was in short eyes. We have compared 60 eyes of patients undergoing cataract procedure with a sclerostomy and without sclerostomy. Number one, sclerostomy definitely helped in reducing complications, more significantly with uveal effusions. However, in both the groups, there were patients undergoing both the procedures, that is phaco with sclerostomy and SICS with sclerostomy. Similarly, phaco without sclerostomy and SICS without sclerostomy. So in both the groups, either of the groups, the SICS had more complications than phaco. The rationale here is we need to have a smaller closed chamber, because there is kind of like undue pressure that can develop during surgery. And this pressure differential is the main reason for most of the complications. So it's also preferred to use AC maintainers. Make sure that you always maintain the chamber. So that is the key here. So in an SICS, although it is a tunnel wound and all that, we have a larger incision, and these eyes are more prone for positive pressures intraoperatively. So that can itself cause a lot of intraoperative surprises.
Dr. Ravindra, I'm sure you would have an answer different from this too, from your experience. So let's hear from you.
Yeah, I think glaucoma fascinates everyone. So that's the most challenging scenario, and surgical scenario is definitely an option for cases where you cannot manage with the medicines. Number one, I have a lot of questions, Dr. Sharmila. Wonderful presentation. I learned a lot from your talk. One is you said when you are applying sponges, you diluted 5 ml in 2 milligrams, while we use 10 ml in 2 milligrams. And also when you're giving injection, you said you dilute 0.5 in 1.5 ml of this solution. That comes to what is the percentage? Around 0.01 or something?
0.1 milligrams, sir. It'll come 0.1.
0.1 milligrams.
Yeah.
Okay. Then how do you react to people who are using little stronger mitomycin for sponges and little more diluted mitomycin for your I mean, this comes to what we use. I inject the same dilution, 10 ml in 2 milligrams, 0.1 ml of it, less than 0.1 ml, 10 mm away from the limbus. So how do you react to the results between the two?
We actually, one of my
different solutions, yeah.
Yeah, actually, the thing is, sir, when we are using sponges, the concentration of mitomycin is slightly more. The reason, it's more actually. It's more than what we use for the injection. The reason why the concentration for injection is lesser is we really do not know where it is exactly diffusing. So that is one thing. With sponges, you just wash away. Here, we're not washing away.
What is the comparative? You might not have published, but you know, off the cuff experience between the two.
So we have published, right? It has come out in IJO, and the mitomycin C injections are equally, I mean, it is equally effective as that of the sponges. However, only the fibrosis, for the fibrosis was slightly more with the sponges. That's what we saw. And our short-term follow-up was only for 6 months. But regularly we've been using this. One, because actually a lot of situations we have faced earlier where there are some kind of like retained sponges or scleral melt or conjunctival melt, we have seen that again, it is not typically because of the use of sponges. It is because of some negligence intraoperatively, possibly because there was a retained sponge where we did not remove it adequately. But using this injection was kind of like, it was more faster for us, and it was better. We did not find much of a difference when we used it along with the sponges, when we compared a head-on comparison. So that's the reason we have shifted.
Is there any difference in the appearance of the blood post-operatively between the two techniques?
No, sir, not really.
The next is, you showed us a couple of ways of making the scleral flaps. One of them is without scleral flap, like a standard SICS, and making a trabeculectomy there. Is there any difference in the post-op appearance or the results between the 2 or 3 techniques that you demonstrated?
Actually, this kind of technique, what we the straight incision, we have just kept it like the last reserve, and it's usually for brown cataracts because it's very difficult to do it in the triangular scleral flap where you might be having difficulty while you deliver the nucleus. So personally, I have looked into those kind of blebs, and I somehow felt that the bleb was not so good in those eyes. So I usually reserve it only for the real hard cataracts where you cannot, it's not amenable to phacoemulsification, and I want to have kind of a safe surgery. Or now more recently, I have even stopped doing that, and I probably limit only to doing a cataract surgery and then put them on medications or go for any other alternative. Like in case if they need a good IOP control, I might go for a micropulse laser, which has come out recently. So that's what I would do. Now I've actually, frankly speaking, I've cut down on doing that straight incision combined.
Okay, the last question from me is that as we have shifted to temporals, it's very difficult to do a combined process. That's the reason why I shifted about 2-3 years ago to dual site. I do it superiorly the trabeculectomy and temporally the cataract surgery. My analysis of hundreds of cases show that the dual site technique, that's what Dr. Chitra was telling, dual site technique is mandatory in phaco surgery. But then that's given slightly better results when compared to the single site I was doing superiorly or superior temporally in earlier case. How do you respond to this?
I too feel the same. So the minute you separate the incisions, it is a lot better because I don't know, the kind of like the fibro, there's so much of conjunctiva that you dissect there, and then which induces a lot of fibrotic response. So all that is there. So separating the incision, definitely it is having an added advantage in helping in the success of the trabeculectomies.
Lovely question, but I think we have to do justice to 3 more speakers.
Okay.
So sorry. I mean, it's been a wonderful learning, very nice presentation, Dr. Sharmila.